you all. I hope that for those of you who were here for the roundtables, I hope you found them as stimulating as I did. Just lots of wonderful things going on in our state. My name is Kathy Hunt. I'm an Oral Health Kansas board member as well as the director of Kansas Cavity Free Kids. Our keynote address today is near and dear to me as it is about keeping kids cavity free. We asked a friend of ours from Colorado to join us today who has put to work an innovative model first developed by Dr. Bert Edelstein and Marcy Frosch of the Children's Dental Health Project. You heard about them, a lot about them yesterday. Karen Savoy is a dental hygienist, and she's an associate professor at the University of Colorado Anschutz Medical Campus, School of Dentistry and Department of Family Medicine. She's currently a member of the Colorado Area Health Education Center program team and director at the Cavity Free at 3 project, which is a Colorado-based initiative aimed at improving oral health outcomes for children and pregnant women. Karen graduated from Louisiana State University and spent 30 years in clinical practice prior to her current focus on education and disease prevention. I first met Karen a couple of years ago when she presented a poster about her initiative at the National Oral Health Conference in Pittsburgh. I furthered my acquaintance with her this spring and in Milwaukee, and she continues to blow me away with her excitement and passion about the work she's doing to help keep kids cavity free. Please join me in welcoming Karen Savoy.
Thank you so much for having me. I'm honored to be here. I spend most of my time and effort in Denver, and I don't get to get out very much. They keep me in the office, behind the computer, coordinating. That's my main focus. But I'm thrilled to be here and share the project that we've done in Colorado. We're very fortunate to be well supported, and we've gotten a lot of national recognition. We recently transcribed all of our PowerPoint presentations into Spanish because we actually have an international, we have a member of our technical assistance team doing some mission work in Guatemala. So if you have need for a Spanish PowerPoint aimed at providers, we have it and we're willing to share. Please know that our website contains all of the information that you'll hear about here. I don't think it's necessary for you to take a lot of notes. You can log onto the website and find everything that we're going to talk about. So I'm going to go ahead and share the project that we have so successfully started in Colorado, and I hope you can make some connections and it's valuable information to you. Again, thank you for having me. So Cavity Free 3, this is just my, I have to show a little bit of Colorado because we have such a beautiful state. Everybody been to Colorado, right? We're so close. So this is Maroon Bells, in case you have not visited. This is up in Aspen. It's a beautiful part of our state. So I just wanted to give you a little bit of information about, again, who I am and where I come from. I have to give mention to our funders, and I know funding is an important topic for all of us, but in Colorado we are the only oral health project, we're the only health project that's funded by multiple funders. So we were able to get a little bit of money from a lot of people, which turns into a lot of money. Once we started this project, we had a lot of requests to participate from foundations. So we are funded by, I'm sure this is familiar, you have this version in your state in one form or another, but these are all the people that put in a little bit of money into Cavity Free at 3, which turns into a lot of money. In June of 2012, we got refunded for a period of 2 years to the tune of $2.4 million, unsolicited funds. It's unbelievable, the support that you get. Once you get a program that's up and running and successful, people want a piece of it. They want to be on the bandwagon, they want to ride on your coattails. So we've been able to do that, and $2.4 million unsolicited saved me a lot of late night grant writing time. You don't have to do any of that. So please know if you can combine those forces, you can really run a successful program. We have no significant funding. I wish I had stock in fluoride varnish. I say that all the time, but we do not. I'm required because of my continuing education component to this presentation, and when we do it in Colorado, to let you know that we have nothing to disclose. So effective intervention, how do we do this? Where do we get this information? How did we get this up and going? We really looked at several components as to what we wanted this to include. And we took this directly from the research that we mentioned before, Bert Edelstein's work, that we had to have a fluoride application component. We had to talk about the bacterial transmission component, which is new to a lot of providers. General dentist, pediatric dentist, MDs, pediatricians, family docs. This is something that is the aha moment in our presentation. The use of xylitol, how to get kids in. We did a really great job of training primary care providers in Colorado to identify disease, but we have not done as great a job in having them have a dental home to receive them. So I'm going to talk to that a little bit more about how we have tackled that problem, what we're doing to increase the number of dental providers willing to see children at the age-appropriate time of 12 months. That's our clinical treatment access dilemma, and then of course the motivational interviewing component, which is so important. Cavity Free at 3 aims to educate health professionals across the board. So we are not limited to one, dental providers or nurses or nurse practitioners. People ask me all the time who can attend Cavity Free at 3 presentations, and my answer is standard. It's anyone who will listen to us. All are welcome. Anyone who wants to come, we want them to be there. If we can just raise awareness on some level. We do a lot of presentations to daycare providers, home visitation, individuals, doulas. My favorite is the doula, because I didn't even know what a doula was. Now I know what a doula is, and that doulas are really important. So doulas come, we will train anyone who's willing to listen. We really want to facilitate the implementation of an infant oral care model throughout Colorado, and our special target audience is underserved population. Those children and those individuals, children, pregnant women, with the greatest barriers in access to care. I know this is what you're working on. We're all working on it. Eva Polson, the director of Salud, which is a big safety net clinic in Colorado, spoke to me one time and said, you know, we're all tugging on the same rope. And I think that's so true. We're all trying to get the same thing accomplished. And if we can join forces and get all these people involved, we can really move the needle on decay rates. In Colorado to start, but nationwide. I really want to see, we have so much focus on oral health now. Once the Surgeon General brought oral health to the limelight, we have so much focus. We need to take that and run. We can't wait for something to happen. We have to be proactive. So the more people we can get to join the mission, I think the easier it is to accomplish this. Our vision in Colorado, we're going to go two more steps. Next slide. So our vision in Colorado is that all children, regardless of where they live or what insurance status they have access to preventive oral care at a dental home starting at age 1. Starting at age 1. Really important. We've trained 1,625 licensed medical providers in Colorado to deliver oral health services in a wide variety of settings. I say wide variety. We're talking about public health settings. We're talking about anything from a well child visit to a public health setting to a community health fair. Again, anyone who will listen, and any place they'll listen, and any place they'll work to do it. We have not had any barriers to say, no, you really shouldn't be giving oral health education at the 9 News Health Fair. You really should. I can't think of any, I've not ever denied a request for training because the audience wasn't appropriate or I didn't feel like we were going to have an impact. We'll go anywhere. We'll listen, as long as you'll listen to us, we'll come and share our model. Importantly, we distribute an oral health kit through our trainings that has a toothbrush for the mom and a toothbrush for the child, and some oral hygiene instructions, some fluoridated toothpaste, all of the pieces to the message that we're trying to deliver. And we track how many children we actually outreach by the number of kits we distribute. And we know we've distributed 30,000 kits in Colorado. That's 30,000 kits that providers have purchased and distributed to families. So that's our impact to children, is 30,000 kids. Before I took the job as director for Cavity Free at 3, Kathy did a great job. I did practice dental hygiene for 35 years, probably longer than some of you are alive. But I did practice dental hygiene for a long time. When I left the clinical arena, I took a job at Children's Hospital, at the Children's Hospital, which is now known as Children's Hospital Colorado. They came looking for me. Someone called and said, will you come and help us to organize these dental providers because we have this mass number of dental cases of kids going to the operating room. And I thought, well, why not, you know. They offered me a great salary and parking and benefits. And I thought, sure, I'll do it for a while. Well, for 7 years, I ran the operating room for dental providers at Children's Hospital. I had 63 pediatric dentists that came every day to that hospital, put kids to sleep, and did complete oral health rehabilitation, is what we called it. It was a huge job. I learned a lot. I'd never been in an operating room, not at that capacity, and I'd never really understood what it took to get a child to come to the operating room. Well, after 7 years, I thought, I used to measure my success on the more cases I did, the better job I was doing. I was more successful. My first year at Children's, we did 1,300 dental cases, and I was on top of the moon. I was like, oh, this is great. I love this job. This is what I need to do. This is where I belong. By the time I left, we had increased capacity in the operating room to 3,000 cases a year in 7 years. And I had one of those moments when I thought, this is really not success. The more children that I'm bringing is not a measure of how I should measure my personal success. So I completely had a middle of the night, wake up, aha moment. I drank the Kool-Aid, call it whatever you want. I was standing on the side of the mountain saying, I can do this, I can do this. I realized that success would be to decrease the number of cases that are coming to the OR, not to increase. So I went to the director of perioperative services and I said, why are we not having some type of educational component? These children are coming, and within 18 months they're coming back. And the parents are professing in the admit-discharge area, we'll just bring them back to the OR. In Colorado, this is a covered benefit by Medicaid. It's covered 100%. The parent has no buy-in, no motivation to change. So I initiated a program where the admit-discharge nurses were giving education. And all I wanted them to say was, do you know this is preventable? Do you know that your child does not have to go through this? Do you realize that the anesthesia that we're giving to your child is the same anesthesia if they're getting a heart transplant? There is definitely a risk. It was just too easy for these families to come to the OR, get their teeth fixed, and go home and continue the same not so great behaviors that got them there in the first place. So we started a program with admit-discharge nurses where they provided some educational material. They had a brief conversation as part of the intake. And all of a sudden, we had openings in our schedule. I thought, this is not hard. This is something we can all do. So we joined forces and we actually implemented the cavity-free at 3 model into the program, into the protocol for operating room procedures. And I wish I could tell you that we only have 1,300 cases again. But this slide is really going to show you how many children in Colorado receive that hospital-based care. We're not there yet, but at least we have a plan on how to get there. In fiscal year 2009-2010, we had 6,000 children receiving hospital-based care, costing Medicaid $8 million. So, thinking outside of the box again, I want to take that $8 million and redirect that cost to try to provide more preventive services and maybe decrease the compensation for these huge restorative cases. We'll talk a little bit more about that. We did 2,873 cases in 2009. That's the 3rd highest utilization of an operating room time in Children's Hospital Colorado, behind ENT and pediatric surgery. Not a statistic that I'm proud of. If we look at the cost to Medicaid for those 2,800 cases done in 2009, that's $43 million of taxpayer money we use to restore a preventive disease. We've trained 1,750 individuals. We actually, I wish I could tell you I was responsible for those trainings, but we have a very active technical assistance team and master trainers of 54 individuals that we've trained to go out and do presentations on behalf of Cavity-Free at 3. That's key to our success. The more people you have in the parade, the more followers you will have to the parade. So we've done 405 trainings, again 28,971 fluoride varnish kits. Not everyone who professes Cavity-Free at 3 is using our fluoride varnish kits, so we estimate our outreach to children to be over 50,000. This next slide shows you where our master trainers are located. Everybody wants to live in Denver. We have a lot to do there. But we have a huge rural population in Colorado, much like you have here. And where we really need the help is out of that I-25 corridor. So we've identified trainers strategically. We're working on the northeast corner of the state, but this is where our trainers live, so they can cover by region. Lots of people participating. We pay our trainers very well. We have the budget to pay them for presentations that require an overnight stay. They're paid $1,000. If they have to travel more than 250 miles, they are paid $500. And if it's in their local community, which is the majority of our presentation, they're paid $250. Presentation is 4 hours. So we have a lot of people who want to be trainers. We have a lot of people willing to help because it's financially advantageous for them. So our first step, we really wanted an effective innovation tool. This was where we thought we would begin. And I want to share the success of the Denver Health Project because I feel like this is really probably our most successful intervention. Since 2009, we've trained 250 providers, meaning pediatricians and MDs in the Denver Health System. Denver Health is our huge FQHC in Colorado. We treat a lot of patients. They treat about 40% of the Medicaid population at Denver Health alone. 5,000 children have received well child visits there within the cavity-free at 3 model. So we did an early intervention in 2009, and we talked about cavity-free at 3, in early 2010. I knew that wasn't right when I said it, but we talked about the cavity-free at 3 model. We had the primary care provider, the MD or pediatrician, deliver oral health services, and we measured decay rates. Then we came back 2 years later and we measured decay rates again. So we're looking to see if the program is effective. 5,000 children have received well child visit encounters at Denver Health through the cavity-free at 3 model. So this slide is going to show you that when we started, we set the bar. We wanted 75% of all children seen at Denver Health for a well child visit to have received a fluoride varnish application. So that's the bar, that's the orange line in the middle. When we started, obviously we were at the bottom, no place to go but up, right? So we didn't have a lot of encounters there with people getting oral health education as part of a well child visit, as part of their standard. They didn't have to have a dental visit, they were seeing the pediatrician. We know they're seeing the pediatrician sooner and more frequently than they're seeing the dental provider, right? If you look at the immunization protocol, there are 8 opportunities for the primary care provider to deliver these services before the child even reaches the age that we recommend a dental home. So we want them just talking about oral health, giving it some importance, stressing the importance of the diet, what the parent can do. So this is what was done in 2010. And I'm happy to report that in January of 2012, over 80% of the children seen at Denver Health are now getting fluoride varnish and education as part of their well child visit. This is a great chart that shows you, and I've spoken to this earlier today with some of you in the audience about how many people, what the discipline is of people that we train. And I understand here that the problem may be a little bit different, but in Colorado we have no problem recruiting medical providers to attend our trainings, mainly because they get compensation for delivery of those services through Colorado Medicaid. That's definitely a driving force. If they can get paid for their time, they're willing to do it. When we had a policy change in 2009, we approached healthcare policy and finance and said we want to be able to compensate primary care providers for this, but the dental population said that's all fine and good, but they need some instruction. We don't want medical providers to just go in there, take a look and say, yeah, I screened them, they look great, no decay. So in order to receive that compensation in Colorado, you have to have either completed an online module or attended a live cavity-free at 3 training. What a driving force for cavity-free at 3. At one point we had 180 practices in our queue waiting for training, because in order to get that compensation, they have to have this training first. Make sense? Healthcare policy and finance was like, yeah, it'll limit the amount that we have to put out. We know that they'll be getting a quality service. Everybody will get the same message delivered so that the families are getting the same message. So if they go to Dr. Jones uptown and they go to Dr. Smith downtown, they're all getting the same message because they've sat through a cavity-free at 3 training. So we've done a really good job in training training medical providers. So you can see the medical practice really takes up about 30% of what we train. And the dental providers is such a small component, 4%. So now we're working on what I call Cavity-Free at 3 2.0, which is going to try to engage the dental providers more. I was recently interviewed for a nightly news presentation at a local channel, didn't realize I was being taped, and when I spoke, I said, we're targeting dentists now. Oh my goodness, we don't target anyone. I got more phone calls. We're trying to engage dental providers to join us in our successful mission, because it was not the right choice of words. So if you are, I'm being taped, so I'll be very careful of what I say. This is where we have training locations. You can see it kind of follows where our trainers are. But again, I want you to realize that we don't have a lot of impact in the metro area. Where our impact is greatest in those areas that don't have dental providers. So those are the areas that medical providers really need to step up, and they understand that. So if we have a family doc, I always pick on Ray, Colorado, because it's pretty far out there. And Yuma, you can see up in that very upper northeast corner of our state. The closest dental provider is probably 30 miles, and that's just a general dentist. So there's not a lot of access for kids to be seen in Ray and Yuma, Colorado. So we've done a great job of training the family doc and the one nurse practitioner in the area to do oral health screening and education so that that child has less dental need in the long run. I think that's key to understanding the success, is that we have a lot of populations in Colorado that don't have access. We have 8 counties in Colorado that don't have a dental provider at all. So again, that's the workforce issue, trying to get people to go to those areas. But this is where we've been able to deliver services most appropriately, in my opinion, is to those areas that don't have a dental provider. Another thing we've been able to do at the University of Colorado is actually incorporate our program into the curriculum in all disciplines that we train on campus. So we have a school of medicine, we have a school of dental medicine, we have a nursing program, we have a physician assistant program. I've trained the pharmacy students, and we've trained the physical therapy students. They're all healthcare providers. If nothing else, if they have questions, they can intelligently answer questions that they receive from their patients, even if they're not coming for an oral health encounter. It's sharing the love. It's all pulling on that same rope. So now it is part of the curriculum, and they're required to have a cavity-free presentation, all students, so that as these students leave our university and go nationwide, they're aware of the importance of oral health. And I don't know about you, but I still believe some of the things that I learned in dental hygiene school at Louisiana State University in the 70s. It's hard for me to accept the new changes. For instance, I learned that we didn't see children until the age of 2. When I heard we were seeing children at the age of 12 months, I was like, but that's not what I learned. We need to really keep up, and if we can get these students engaged while, as part of their education, we know we have them for a lifetime. So our next step, I want you to understand what the Cavity-Free at 3 program is. We have a child oral health presentation, a perinatal presentation. We do believe that oral health, good oral health begins before birth. So if I can get the pregnant mom, or there's no such thing as the pregnant woman, healthy, dentally healthy, the child's got better outcomes. There are tons of studies reporting this. We know this works. How soon is too soon? What comes first, the chicken or the egg? What comes first, the child or the teeth? To me, the teeth. So if I can get those teeth healthy while the mother is still carrying the child, then the child has a better chance of long-term improvement. We have recently developed a dental-specific module. If I went into the dental offices with my standard Cavity-Free at 3 training and talked about this is a white spot lesion, this is what you're looking for, and this is an appropriate use for fluoride, and this is the education you could get. I tease my coworkers, I probably would have tomatoes thrown at me and get off the stage. So our dental-specific module is really targeting the business model and how they can make money by seeing these Medicaid patients. That's really, it has to be the focus for dental providers, because they know the science behind it. I don't want to insult them. I don't want to give them information that they're already well aware of. They spent many years and much effort to learn that information. So it's a business-based model. Our master trainer team not only has people in Colorado involved, but we have a master training opportunity coming up in 2 weeks that we have invited people from all over the country to come. We got a small grant from the American Academy of Pediatrics they have oral health advocates by region, and we're bringing in an oral health advocate from each region of the country to come and learn this model so that they can take it out and see how they can implement it within their state. And then our evaluation projects are actually funded separately than the Cavity-Free at 3 model, which is key. It really puts a lot of people who are good at evaluation and more skilled than I am. I am an educator. I can go out and talk in front of people. This is what I enjoy doing. But I don't understand Z-scores and N's and all that. stuff. When I go to those meetings, I feel like I'm talking well over my head. So we fund that independently of what we fund for trainings. We're very fortunate. Again, funded by all of the foundations, but it's a different type of funding mechanism. Our program really aims to prevent disease, education, integrate oral health care and prevention, training, training, training. The more trainings we do, the more people we have joining the team and following the mission. And then we have a comprehensive cavity-free website. If you haven't visited it, I hope that you will, because it's got a lot of tools there. This next slide will give you an idea of what it looks like. We have care to kids, care to pregnant women, how to get paid. This is a really great, I call these the buckets on the top. This is how we engage dental providers on how they can actually become Medicaid providers here. If they have any problems, they can get support here. We have a dental calculator that you can put in some information about if you're willing to see a Medicaid child for in your practice, 1 day a week, 1 hour a day. It will calculate your potential revenue over time, so you can see how much you can increase your bottom line in a year. And it's pretty impactful. And you can do this at your own leisure, your own time. We use it as part of our presentation, and it's pretty powerful for people to understand that it's important to see these kids. But all of our resources are here. These are 3 of our dental health champions in Colorado. This is the president of the Colorado Dental Association, Quinn Dufarena. Chris Urbina is the director of the Colorado Department of Public Health and Environment, and Katya Maritson is our state dental director. So we have a lot of support from those individuals that are key in working in oral health in Colorado. Some of the tools that we offer, we have a child oral health brochure, a perinatal oral health brochure, as well as an information card. All of these resources you can print from our website. Nothing is copyrighted, nothing is protected. It's there for your taking. The funders have insisted that we make this easily accessible to the public. We get a lot of requests. We are happy to provide these educational brochures, but I think the graphics are there and easy to understand. All of our educational material is written at the 5th grade level, so it's easy to understand. Yours for the taking. This next slide is going to show you our risk assessment form. Risk assessment is something that we require all of the people who are practicing cavity-free at 3 to do. I tell them, do a risk assessment and document that you did a risk assessment. Because if that patient appropriately winds up in a dental office and has an age-appropriate 12-month visit, that risk assessment form is going to be really important to show change over time. I talked to them about putting the baby to bed with a bottle in February of 2009. Now they're seeing a dental provider. I don't want to have to start over. I want to build on the component that the family already has. So this is our risk assessment form. Any response in a shaded area confers high risk. You've all seen these before. This is based on the ADA risk assessment tool, but this is our risk assessment tool. Take a look at it. I hope you'll find it valuable. Our motivational interviewing self-management goal sheet is next. It's very colorful. Our graphics are all the same. After we give our education, we ask the parent, which one of these would you like to work on at home? And the all-important question as to, how confident are you that you can accomplish this? If we're not going to ask that question, then we're probably not ever going to have an impact and change behavior. So that's really important. You can spend weeks on motivational interviewing, but that's Cavity-Free at 3's approach to motivational interviewing in 30 seconds or less. So the parent selects, and then they sign it, I sign it, the provider signs it. This is a duplicate form. They get to take a part of it home and stick it on the refrigerator, and then when they come back, hopefully we're going to build on what we've learned or what we've taught in the initial encounter. Language translations, this is just something that I'm personally proud of. We've translated our educational material into 10 languages. So if you have any need for this, you can download all of this from our website. Since this slide was made, we have added Burmese. It is on there. Burmese and Chinese were our 2 most recent additions. I like to try to do the educational brochures in a language that I can't find on the internet anywhere. So I look for those really obscure ones. We did Hindi. We have an international program for dental students at the University of Colorado. So we will translate, and then we give this to a student that's fluent in this language, ask them to reverse translate it, and identify a population within Colorado, and we support their outreach efforts to go out and educate that population. So it's a pretty cool spin-off of Cavity Free at 3. But if you have a patient who speaks Somali, we have a huge Somali population in Colorado. If you have a patient who speaks Somali and you want to give them educational material in their native language, you can go to our website and print it off. It's pretty cool. It's pretty cool. And if you have a language that you haven't had, you don't see here, you'd like to see done, if you send it to me, I'll see about having that done. I just got a request for Hmong. I've not seen anything. We have German. German was easy. German's been done, but I've not seen Hmong done anywhere. So please look at it. It's great. So let's talk a little bit about evaluation. I know that's what you want to hear about. That's what everybody wants to hear about. We can say how great we are, but unless the numbers show it, are we really that great? So we've got an evaluation project looking at the effectiveness of the Cavity Free at 3 model. We have another project that I'm running about the training at the time of presentation. So we actually survey people at the end of the presentation and ask them, how did we do? Were the materials effective? Was the speaker effective? Things like that. And we're looking at changing caregivers' beliefs, behaviors, and experiences over time. So this is targeting the people who are actually delivering the model, mainly MDs, but some DDS, RNs, PAs, APNs, you name it, we have them all in our presentations. And then we're going to measure rates in children exposed to the Cavity Free at 3 model. And then we have one last evaluation project that deals with pregnant women. So we know that the services are being delivered. We can actually pull the data out of healthcare policy and financing. When we designed the Cavity Free at 3 model in Colorado, we left the D code. So dental providers here, we left the D, we do the D0145 and the D1206. We left that code and we let medical providers now build that code. It was a genius idea because now I can pull D codes from the medical side and know exactly how many oral health encounters are being delivered by medical providers. It's approved in the system. It was the easiest way, rather than make another code and have a doctor deliver a D0145 and they're calling it a CV or whatever their CPT codes are. We allow medical providers to use the same dental codes. So when we pulled data out of HCPF, we know exactly how many of those oral health encounters are being delivered. And in 2009, we billed $15,905 worth of fluoride varnish and education and counseling of the primary caregiver for a child under the age of 3, which is a D0145. And then in 2010, we delivered $169,000 worth of those services. That's huge, tenfold. So we know the medical providers are doing it because it's easy to pull the data. Is it having an impact? We don't know yet because it's not been long enough. In the first 3 months of 2012, we delivered $116,000. So based on those projections, in 2012, we will have delivered $464,000 worth of oral health services from the primary care side. They're doing it. We know they're doing it. Now we need to figure out if it's working. Effectiveness at the time of training, most of the people that we identified, we had identified 463, we surveyed 463 participants in Cavity Free at 3 training, and of that we got 369 responses, which is pretty darn good. We recently did a paper survey, Kathy, I thought of you, to all of our dental providers. We sent out 1,603 paper surveys. That's a huge expense in case you don't know. We got back 37. 37. So interviewing or evaluating at the time of training is the way to do it. Because usually I'll give them a toothbrush if they complete the evaluation or some type of motivation. So we had a very strong, they either agreed or strongly agreed that the information that they were receiving was effective and the facilitator was effective. Always room for improvement, but at least they felt like at the time of training they got what they came for. The contents were clearly explained, the information was useful, it was connected, the information was connected to the training that we were asking them to go out and do. So if I can establish that happiness with what they're learning from the initial encounter, it's much easier to have them come back to the information. Make sense? If they told me that they liked it when we did it, hopefully they'll still like it in a week and in 2 weeks and in 6 months and in a year. So if we can get that initial validation of the information as helpful and useful, they'll continue to do it. This next study talks about attitudes, beliefs, and behaviors of the caregivers. So this is the physicians who we're asking to do the training. This is not measuring the decay rates in children yet. We're asking physicians, do you feel like you can deliver oral health services effectively? So this again was very positive. We had 203 people surveyed before and 296 after, and they all felt like their ability to deliver oral health services as far as brushing a parent brushing their child's teeth, their belief in what they were talking about went up over time. We wanted to measure those key messages of, are you brushing your child's teeth? Are you using fluoridated toothpaste? How about what your child is snacking on? Are they going to see a dental provider? These are all questions we really want to know. And lastly, are we drinking water that has fluoride? I don't want to use that question in Kansas, right? I'll be afraid. In Colorado, we fluoridate 70% of our municipal water, so we're not at 100%. Question, please.
Limiting my child's sugary snacks, it looks like it went down.
It did go down. It did go down. And we feel like that, the reason for that is they felt like they're getting so much benefit from all the other things that they were doing, they could go ahead and give them a few more fruit snacks or whatever. So they felt like, obviously the diet was not an important component to the parent, as important as all the other great dental tool and information that they had learned. So it's difficult to get a positive response for everyone, but they thought it was okay because my physician put fluoride varnish on, so it's okay, they can have more juice. Interesting, isn't it? Kind of a blow up in your face moment. Again, the same survey. We had raised awareness about the importance of having a dental encounter. This is something that the dental people really feared, that the patient would have the false sense of security that they were receiving dental services from their medical provider. So we wanted to make sure that the dentist's needs were met. Thank you. And that they realized that this was just a screening they were getting at their healthcare provider. They still needed a dental home with comprehensive dental services. Our Bright Smiles program addresses pregnant women. This is something we're very proud of. We've treated 1,500 pregnant women at Dental Aid, which is a safety net dental provider in Colorado. We average 400 women per year for the last 3 years, and we provide them with free dental care. This is a grant-funded project again. So we get pregnant women in, we get the mom healthy, and then we measure decay rates in the children. Seems pretty simple, right? The big thing that Dental Aid has been able to do is provide a case manager, which is crucial to success of this program. Many of these patients are non-English speaking patients. The extent of my Spanish is abra la boca. That's all I can say in Spanish, which means open your mouth, and then I can say abra la boca grande, and that's it. So it's difficult to give oral health education to a Spanish-speaking pregnant woman, so we hire case managers. But here, I think this is really important. We had 250 patients before Bright Smiles. We had decay rates of 1.08, and if they did not receive Bright Smile intervention, their decay rates were 3.38. But the most important and impactful data to me, again, what I started out to do, is the number of children going to general anesthesia, the number of children to these Bright Smile mothers went from 44% to 8%. So we were letting the mom know her oral health was important, the oral health of her child was important, and general anesthesia no longer becomes an option for these families. It doesn't have to become an option. That was huge. The next slide is going to talk about how much money we anticipate we could save from a project such as this. You know, you get a lot more endorsement from federal dollars and from healthcare policy and financing funding when you go and ask to change the compensation rates to pay more for preventive services and less for restorative services. If you can show a cost savings of $9 million in a year by delivering preventive services to the mom, they're more than happy to increase compensation for those services. So we estimate the potential saving of $9 million just from the Medicaid population for treating pregnant women. And I think it's important to realize that that's where you have to start. You really can't start with the child who already has decay and try to change the behavior. We're all about prevention. We want to see them as early as possible. We want to see them in the womb. We want to be able to start that education while the child's in the womb. So what's next? Unfortunately, individuals who face the greatest barriers to care are often the most vulnerable members of our society. How can we reach these children? How can we put our arms around them and make sure they have established dental homes? In Colorado, 96% of pediatric providers accept Medicaid. Dental providers, we don't do as great a job. In Colorado, only 20% of dentists accept Medicaid. So we can go out and train the medical providers, we can give them all balloons and horns, and we're all marching down the street to save the children of the world and make sure they stay dentally healthy. If there's no dental home for that child to go to, will we ever really make a difference? So we did focus groups. We did 9 focus groups across Colorado when we said, would you take Medicaid? Why don't you take Medicaid? What are the barriers to seeing Medicaid children? And we thought we had it all figured out. We thought they were going to say, we don't get paid enough. Compensation rates are too low. I get more compensation from privately insured patients. That's the last thing that we heard. People really do want to do a good thing. I think dental providers have that sense of altruism where they really want to provide care to their patients and to their community, and they want to be well respected and thought of. The biggest barrier that we had, they don't want to see them when they're a year old. They were afraid of the 1-year-old child. I was shocked. They don't talk back. You can do a knee-to-knee exam. You can get the child down and do an exam in a very short amount of time. And hopefully, the 1-year-old, you have the opportunity to make the biggest impact because you're going to get preventive services there. You're going to talk about education. You can put fluoride varnish on. So that 1-year-old becomes a 2-year-old that's cavity-free, becomes a 3-year-old that's cavity-free. It was really an interesting finding for us once we realized that we had to direct our services in how to treat a 1-year-old child. So that's really what our educational program is based on, is treating the 1-year-old child. Compensation wasn't a big thing. We asked Healthcare Policy and Financing this year for an external audit to see how we could save them some money, and they have agreed. This is coming from foundation funding again. And what we're asking for is to increase compensation for preventive services and decrease compensation for restorative services. And if you attend Cavity-Free 3 training in the state of Colorado, you'll get an enhanced compensation. So if you practice the model, I tease my dental providers, you'll get 35 cents on a dollar instead of 30 cents on a dollar. But it's still a huge motivational tool that we can offer them if they just help us join forces. If we can all work together and they can increase their compensation by a small amount, it's very effective. We have had more interest from dental providers than we ever thought that we would. In Colorado, this is our fine governor. We have identified oral health as one of the 10 winnable battles for public health. This was a huge thing for us. We got the endorsement of the governor, so oral health has been brought again to the spotlight, and this is what we are trying to do to win that oral health battle in Colorado. We want to increase the proportion of children on Medicaid and CHP Plus who have an annual dental visit. We know now that 90% of children are receiving immunizations in Colorado, and only 40% are getting a dental visit. So if we can decrease that huge gap between those two, we'll make a difference. We're wanting to increase the number of children that have a dental visit by age of 1. Only about 30% of children in Colorado have a dental visit by the age of 1, and that was a lot higher than I thought it would be. But we want to get that up. I like to set small goals, small steps, right, by 5% in 1 year. If I could do that by 5% in every year, then it would really have a difference. So we have very concrete steps for us to feel like we're getting where we need to get to. The most difficult one is reducing dental caries in children. Our first study done at Denver Health, the innovation study that I talked about in the beginning, we know these children are getting fluoride varnish, but are we really reducing their decay rates? We had this huge project, and we had this big meeting plan. We were going to share the results of that data. That's to be published in the American Academy of Pediatrics next month. So I can't give you the specifics, but I can tell you there was no dancing on the tables. We didn't move the needle as much as we thought we would. And we feel like, we have, at the university, we have these biostatisticians who can take data and have it spit out. You put it in and they'll spit out whatever you want. they couldn't really spit out a decreased decay rate because we felt like the key was 4 fluoride varnishes over a period of 18 months. So now we're redirecting our efforts to see if that's going to make a difference, because we did not move the needle significantly to decreasing decay rates. And improving the rates of community water fluoridation, that should be easy to do in Kansas. We're just going to get it going, right? So Cavity-Free 3 2.0, what I'd like to talk about, this is what we are trying to do in the future. We want to increase the number of dental providers willing to treat young children and pregnant women. We want to increase the number of dentists that will accept the Medicaid patient. I really enjoyed the presentation yesterday about the insurance exchanges here. We have the same issues in Colorado. I just want people to realize that in our state, 40% of children in Colorado are going to be covered by Medicaid if the current guidelines are still in force in the future. That's like half the children in the state that are missing the opportunity to have a dental visit if the provider doesn't accept Medicaid children. So we're working on that. And we want to know that the dental population is well aware of the age 1 dental visit. As a result of our focus groups, we found that was one of the areas that we weren't really communicating very well. The face of our Cavity-Free 3 child, I really want to have some discussion and see what questions I can answer for you, and what information that you feel I have more to share about. The next slide is my contact information. Please feel free if there's information that I can give to you as far as translations, educational brochures. We have funding and the budget to mail these documents out to you. I love sharing across state lines. I think it's important. I hope that you can realize that I'm very proud of the project and we've done some great things. And I want to know how I can help and what barriers you've had here. Questions? Please.
What is a doula?
A doula is an individual who's trained to deliver a baby in a not so normal setting. So they go to your home. We have a lot of water births. Remember, Colorado is kind of a progressive state. We have the Republic of California to the west of us, but we have Boulder. They have tons of doulas in Boulder. We have a lot of home births, water births. They bring in these portable tubs and they get the mother in there. So that's what a doula is. It's a mid-level gynecological obstetrics provider.
Thank you.
Yeah.
Who adds the additional cents to the Medicaid reimbursement for the dentist? Is that
Who adds the additional compensation? We maintain a database and we report that monthly to healthcare policy and financing. The names of individuals trained in Cavity-Free 3, they just check a box in their data system and they automatically, that's not in place yet, but we're hoping that they will automatically get that enhanced compensation.
But that money's coming from Medicaid?
That money's coming from Medicaid.
Okay.
Right. So we're trying to show to Medicaid that if we can deliver more preventive services, we're going to save them money. We can save them $9 million by treating pregnant women. They're all about saving money. We're all under the gun for limited budgets. If I can direct that money to a less expensive service, the compensation in Colorado for the D0145, along with the fluoride varnish, so the evaluation, counseling of the primary caregiver, and the fluoride varnish adds $45 to a well child visit. That seems like a lot of money to the primary care providers who are interested in providing those services, but it's not a lot of money to Medicaid when it takes $15,000 to take one child at the OR. So they would much rather, I can do a lot of fluoride varnish and early intervention with $15,000. So that's why they're very interested in what we have to provide. We've also approached in Colorado the private insurance to see if we can break ground and allow primary care providers that are not only treating Medicaid patients but privately insured patients. So we've had conversations with United Healthcare, and I shared this with the booth back there, that we are trying to get primary care providers compensation for privately insured children. They want to see the data, they want to see that it's cost effective, and any insurance company would want to implement that same thing. Pay more on the preventive end and less on the backside. The time is ripe. We all hear about the low-hanging fruit and how to get that going, but the time is ripe for us to really look at some of those redirecting of cost to the to the insurance companies, to the privately insured and to the publicly insured, to try to get preventive services more to the top of the table. Because it's better for the patient, it's better for the family, saves them money in the long run. It's a win-win situation. Question? Yes, please.
You mentioned that fluoride in the water, of course, was.
It's a huge part of our conversation.
Fluoride varnish was, but then you stated that the fluoride varnish maybe did not affect the overall health in the one study that you did. Do you have a feel for any of the other preventive, you know, the don't drink in a bottle, no juice, no candy, no pop, any of those that are as helpful or any that rise to the top?
I think that your question is really important. Any of us that have delivered dental services over time realize it's not a simple solution. Fluoride varnish I don't think is the tipping point that's going to really make the difference. It's the change in the behavior. I think we need to direct our efforts more, because the question was raised here about why the parents didn't feel it was as important to not limit the sugary snacks that their children are receiving. I think people see a fluoride varnish as a cure-all, that, oh, we got fluoride varnish, so now they can eat more junk and they can have more juice. So I think really the key to success is changing attitudes, beliefs, and behaviors over time. I think the fluoride varnish, we thought that was going to be the cure-all, that all we had to do was put fluoride varnish and decay rates would go down, but we've proven time and time again that that's not the case. I think we need to direct our efforts more to changing behaviors. That would include fluoridated toothpaste, drinking tap water that's fluoridated, brushing your child's teeth. We have the ad council now that we're all very excited about, to brush your child's teeth twice a day for 2 minutes, 2 minutes twice a day. That's the new catchphrase that's coming out. I think it's changing the attitudes, beliefs, and behaviors of parents. And that's probably the most difficult one to accomplish.
Yeah, I had a question regarding your risk assessment that you do. If I understood you right, it sounded like there was one for physicians to do at medical offices, and then you were referring them that a dentist would have access to that information when they met to the dental office. Are physicians putting that information in an electronic database somewhere?
I wish we were there. We're thinking about that. Our risk assessment form has 2 versions, one for the medical office and one for the dental office, but they're essentially the same. The only difference is on the dental risk assessment tool, we have 3 categories for risk. We have low, high, and extreme. Dental providers requested that because if we identify a child as being extreme risk, we can do fluoride applications in a shorter period of time. That's what dental providers like to see. So they'll bring the child in and do a fluoride application, do it a month later, and then a month later. That was something that we felt like dental providers needed, that ability to do that. Our risk assessment form is a duplicate form, so a copy is provided to the parent to take to the dental office.
Okay.
So it's an NCR form, you get 2 copies. We have requested that fluoride varnish be added to our immunization database in Colorado. So when a child receives their immunizations at the pediatricians, they will record that they got fluoride varnish, and the dental provider can look at that and know, because we have a limit of 3 fluoride varnish applications in a year, and we don't want that child to go to the pediatrician and get one at 6 months and then get one at 9 months and at 12 months, and by the time they go to the dentist, they've maximized that benefit for a year. So we're trying to play nice in the sandbox and have the medical providers and the dental providers coordinate that effort. So we're trying to add that to our immunization registry. We've also created what I call the nail card. Any of you that get manicures, you go to the manicure and you get 12 manicures and you get $10 off your next visit. We've created one for fluoride varnish. So the parent carries that around, and the parent, when they go to the physician, they write the date that the fluoride varnish was taken, and then they take that to the dental provider, and the dental provider sees that they got it. They don't get a free one after 10 pedicures or 10 fluoride. But we created a card that's easy for the parent to remember to carry around. It was really a great idea, and has been more successful than having providers document in the database for immunizations that fluoride was applied. That's one more step. and that's been a little time prohibitive from the medical provider side. If I can give responsibility to the parent for that, it's much more effective, because the parent has 2 children, the pediatrician has 10,000 patients in their practice. So if mom can carry the card in her wallet when she goes to the dentist, she feels really empowered by the fact that she knows that her child got fluoride varnish and when. So she pulls out the little card and the dentist is like, wow, haven't seen that. It's got the little Cavity 3 logo on there. So that's a more effective tool.
So the children get a maximum of 3 paid by Medicaid, regardless of what, because you keep the same D code, it's whether or not it's.
That's correct.
Okay.
That's correct. So they can't get 2 from the medical side and 2 from the downside. It's 3 total in the period of a calendar year.
Okay.
And in Colorado, those delivery of oral health services have to be incorporated with a well child visit. So I can't have a child call the pediatrician and say, I need to come in for a dental visit. The dentist say, no, 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 that's not a dental visit. So it has to be incorporated into the well child encounter. Really important. They can't come in for an ear check and the pediatrician says, oh, the ear looks fine, but I can smack on another $45 here if I give oral health instruction. It has to be part of their well child visit. That's important to me because I feel like they're already delivering the anticipatory guidance. They're talking about diet, they're talking about seat belts, they're talking about electrical safety. If we can just get them to talk a little bit more about oral health, it doesn't impact the time that they're spending with that patient. That's really important because many medical providers say, we don't have time. We have 20 minutes for a well child visit. I've already got to do reading assessment, mental health assessment, immunizations. I have a lot on my plate already, but if we can show them how they can incorporate it to what they're already doing, they're more willing to do it.
I'm not familiar with D codes, so are they reimbursed for education?
They are. And they're
Pediatricians and dentists?
yes,
Okay.
and doulas.
For 0 to 3.
And any licensed medical provider in Colorado. And the compensation is twice as much for the education as for the fluoride varnish. So we really value the education. They can't give one without the other. If they bill for the education and not the fluoride varnish, Medicaid kicks it out. The compensation for the D0145, which is evaluation of a child under the age of 3 and counseling of the primary caregiver. So you have to look at the teeth, you have to do an assessment, you have to do a risk assessment, and you have to educate the parent. I've not yet met a 1-year-old that I can educate, or I can prop up in the chair and deliver a good dental visit to. So we're targeting the parents. We want the parents involved from the beginning because that's our opportunity to change behavior. The compensation for that is $29.46. The compensation for the fluoride varnish is $14. So the pediatrician and whoever's delivering the services puts more value on the education because they're receiving more money for it.
Is that just a Colorado thing?
It's a Colorado thing, but I've got a great statewide who pays for what in each state. I'll send that to Marcia, and I would love to see that distributed or posted on your website so you can see how states vary. And the states that have the most successful programs pay more for education than they do for fluoride varnish. Just delivering fluoride varnish, unfortunately, we're driven by the mighty dollar. I do what I'm paid for. I try to think that I'm the type of person that does above and beyond what I'm paid for. But when you're looking at a 20-minute appointment and you're asking a physician to add more to an already full plate, unless they're compensated, it's probably not going to get done. And I tell them in my trainings, if I'm going to give you $30 to educate, I'm expecting you to educate, and I'm expecting you to document in your record, this is what I talked about. Don't put the baby to bed with a bottle. Limit sugary snacks. And it's amazing. If you pay them for it, they'll do it. It's the nature of the beast. Fluoride varnish should be your last entry, not your first. So they get that message about the importance of education as the tool to change the future. This is my overachiever table over here. Any questions over here? Yes.
I was going to say on the getting the private insurers to work with you. We had similar experience on immunization in Kansas and Missouri, where they knew it would save them money. The private insurers would if they did it, but they didn't want to be the first or the only because, from a competitive standpoint, their competition would have a market advantage. And what we did in Kansas and Missouri is to mandate no deductible, no copay for childhood immunizations. age 0 to 3. And it was one of the few cases where we could go to the legislature in both Topeka and Jeff City and do a mandate for private insurers. They had to cover it. And they all were okay with it because it kept the playing field level.
That's really great information.
Yeah.
Because everyone, I mean, we want what's best, we all want to save the children, we all have that, we want what's best for our children. But it has been a difficult barrier to cavity-free at 3, because I think all children should receive the services. I don't think it should be limited to one population or the other. So I see practices offering the services, but the parents have to pay for it on the medical side. And I think it's a barrier, it's cost prohibitive to a lot of families. Even the cost of the fluoride varnish and the toothbrush, the little kits that we distributed 28,000 of in the last couple of years, is a $6 expense. So my advice to them is to charge the family $6 for the cost of the kit, but then, again, it's not a hugely successful thing to offer because you're asking your provider to do more on the same amount of money. So it's been a real barrier.
Yeah, the private insurers admitted they saved money over the long run. They also admitted it was, pennies to do it, up front. But even though it was pennies and it was short, a loss in the short term, they didn't want to do it for competitive market reasons. But by mandating it across the board, they were all.
Everybody was forced to join.
Yeah.
Great advice. Well, I thank you very much. No more questions? I appreciate the opportunity to come and share this model with you. I hope that you've learned something about how we do things in Colorado, and please watch us. You can follow us on our website, and we are going to distribute early the results of many of these studies that we're doing. If you're interested in some of the data, those of you that are data seekers, we will have that coming up. So please visit our website, join, follow us, and thank you so much for having me here in Kansas.